Welcome to The Debate. Today we are analyzing a topic that affects, well, exactly what is on our plates every single day. Saturated fat. Heart health, friend or foe? For well over half a century, the overarching medical and public health guidelines have told us to strictly cap our saturated fat intake to prevent cardiovascular disease. But today, a massive scientific reevaluation is underway.
Yeah, it's an incredibly timely discussion. The central question before us is really this: is saturated fat an inherent driver of cardiovascular disease that must be strictly limited, or is its impact heavily dependent on the food matrix it comes in, our individual metabolic risk, and, crucially, what we replace it with?
Exactly. And I will be arguing that lowering saturated fat, and particularly replacing it with polyunsaturated fats, remains a highly effective evidence-based strategy for reducing LDL cholesterol and preventing cardiovascular events.
And I'll argue that the broad universal vilification of saturated fat is, frankly, reductionist and severely outdated. The actual health impact of saturated fat depends on the specific food source, the chain length of the fatty acids, and perhaps most importantly, the severe metabolic harms that occur when we replace dietary fat with refined carbohydrates.
Okay, let's start with the foundational mechanism, because it has stood the test of rigorous scientific scrutiny for decades. The premise is straightforward. Saturated fat raises low-density lipoprotein, or LDL cholesterol, which is a direct cause of atherosclerosis. This is the consensus of major cardiology institutions, which recommend capping saturated fat at 10% or even 6% of our daily calories.
Right, but
And this isn't just theory. When you look at the highest quality data from randomized controlled trials, including landmark studies like the Oslo Diet Heart Study, we see that replacing saturated animal fats with polyunsaturated fats, or PUFAs, slashes the risk of cardiovascular disease by up to 29 to 30%. That is a massive clinical benefit. We are talking about preventing actual heart attacks just by changing the type of fat we consume.
the problem there is that the original lipid heart hypothesis was fundamentally flawed from its inception. I mean, it was heavily championed by Ansel Keys and the 7-country study, which is famous but deeply problematic. They collected dietary data on less than 5% of its participants, around 500 people, and completely ignored the role of refined carbohydrates.
Well, they were looking at specific variables.
Sure, but when we zoom out and look at modern, comprehensive, systematic reviews, the narrative changes entirely. The 2020 Cochrane meta-analysis, which is widely considered the gold standard for evidence review, showed absolutely no significant reduction in total mortality, cardiovascular mortality, fatal myocardial infarctions, or stroke when reducing dietary saturated fat. The hyper-focus on saturated fat as a monolithic evil has blinded us to the real drivers of metabolic disease.
Hold on, let's unpack what that 2020 Cochrane review actually concluded, because this is where the interpretation of the data gets incredibly important. You mentioned mortality, but the authors found a statistically significant reduction in combined cardiovascular events when saturated fat intake was reduced. This aligns perfectly with the core randomized trials I just mentioned.
Combined events, yes.
If a dietary intervention reduces combined cardiovascular events, that means fewer people are experiencing angina, fewer people are needing stents, and fewer people are suffering from the immediate debilitating consequences of ischemic heart disease. Dismissing this finding just because it doesn't always reach statistical significance for total all-cause mortality ignores a very real, tangible reduction in human suffering and cardiovascular morbidity.
I have to push back hard on the value of combined cardiovascular events as an endpoint. It is notoriously subjective. Researchers have pointed out that being in a control group in a dietary trial often leads to anxiety-driven care seeking.
Anxiety-driven?
Yes, think about it from the patient's perspective. They know they are eating the bad fat, so they report more chest pain, doctors run more tests, and suddenly you see an increase in elective interventions like stent placements. But when you look at the hard clinical endpoints, the objective measures where there's no room for subjective interpretation, like actual mortality or fatal heart attacks, the 2020 Cochrane review found no significant benefit.
I think calling stent placements merely subjective is a bit of a stretch.
But they aren't alone in this finding. A massive meta-analysis by Sari Torino of 21 prospective cohort studies involving over 347,000 subjects found no significant association between saturated fat intake and the risk of coronary heart disease or total cardiovascular events. If saturated fat is as uniquely dangerous as the guidelines suggest, a study of nearly 350,000 people over 2 decades would undoubtedly show a clear spike in mortality. It didn't.
Even in the observational studies that show null associations, we have to ask a critical question. What were the participants eating instead of saturated fat? In populations where saturated fat is reduced but replaced with refined sugars and starches, of course we don't see a benefit. But the randomized trials where we strictly control the replacements, specifically swapping saturated fat for polyunsaturated fat, show an undeniable reduction in cardiovascular disease.
That assumes LDL is the only mechanism at play.
It is the primary mechanism. Lowering saturated fat reliably lowers overall LDL cholesterol. Atherosclerosis is driven by apolipoprotein B-containing particles. Think of ApoB as the barcode or the protein tag attached to every single potentially dangerous cholesterol particle. Lowering the total mass of LDL directly reduces the number of these ApoB tags circulating in your blood, which means fewer particles are crashing into the endothelium, the delicate inner lining of your blood vessels, to cause plaque buildup.
Look, the mechanics of cholesterol are exactly where this debate gets fascinating. But looking at basic LDL cholesterol mass is a 20th century way to assess cardiovascular risk. Yes, saturated fat increases LDL cholesterol, but we have to look at the subfractions.
Subfractions are a piece of the puzzle, sure.
They are the main piece. Saturated fat primarily increases the mass of large, buoyant LDL particles. Imagine these as large beach balls floating through the bloodstream. They are minimally associated with atherosclerosis. Conversely, when people lower their saturated fat and increase their carbohydrate intake, particularly fructose and refined starches, it triggers something called hepatic de novo lipogenesis. Essentially, the liver gets flooded with sugar and starts manufacturing small, dense LDL particles.
Right, the small, dense ones are atherogenic.
Exactly. If the large particles are beach balls, these small, dense particles are like BB pellets. They are highly prone to oxidation, they easily penetrate that delicate endothelial lining you mentioned, and they are incredibly dangerous. By fixating on total LDL, we are penalizing saturated fat for raising the relatively benign beach balls while giving a free pass to the carbohydrates that create the truly atherogenic BB pellets.
I completely agree that small, dense LDL particles driven by insulin resistance are highly dangerous. But the beach ball analogy minimizes a crucial point. Those large, buoyant LDL particles are still atherogenic. They still contain that ApoB protein tag. Over a lifetime of exposure, even the larger particles will penetrate the endothelium, get trapped, and cause plaque buildup. It might take longer, but the traffic jam still happens.
But the clinical outcomes don't reflect that traffic jam.
They do over a lifespan. This is why the American Heart Association maintains that lowering total LDL, regardless of the subfraction, is the safest bet for the population. But your point about carbohydrates brings us perfectly to the replacement conundrum. I will readily acknowledge the severe dangers of refined carbohydrates. Swapping a steak for a plate of refined pasta or sugary snacks offers zero cardiovascular benefit and actively worsens metabolic syndrome.
Glad we agree on that.
We do. But that doesn't mean saturated fat gets a free pass. The public health recommendation isn't to eat sugar, it is to eat healthier fats. The data from the Nurses' Health Study explicitly showed that replacing 5% of energy from saturated fats with PUFAs yields a 25% lower risk of coronary heart disease. Even replacing it with whole grains yields a 9% lower risk. The dietary guidelines are asking people to make targeted, heart-healthy substitutions, not to load up on candy.
But we have to look at what actually happened in the real world when those guidelines were published. Starting in the late 70s and 80s, the public health apparatus pushed low-fat diets hard. How did the food industry respond? They removed the fat and pumped foods full of refined carbohydrates and added sugars just to make them palatable.
That was an industry failure, not a physiological one.
It was a direct result of the guidelines. We told everyone to stop eating butter,
and instead they ate fat-free Snackwell's cookies loaded with sugar. We essentially sparked the twin epidemics of obesity and diabetes by myopically focusing on saturated fat. And even today, telling people to replace saturated fat with polyunsaturated fat often translates to consuming highly processed seed oils that have their own inflammatory issues. If we want to look at what happens in the real world, we have to look at the PURE study.
The PURE study has some very distinct limitations based on its demographics.
It was a massive wake-up call because it zoomed out from wealthy Westerners and tracked over 135,000 individuals globally across 18 countries. They found that higher saturated fat consumption was actually associated with a lower risk of stroke, and it had no association with increased myocardial infarction or cardiovascular mortality. In many global contexts, adding calorically dense fat to the diet is protective. We cannot ignore data of that magnitude just because it conflicts with a metabolic ward experiment from the 1960s.
The PURE study is certainly a valuable piece of global context, particularly regarding undernutrition in developing nations. When populations are struggling to get enough basic calories, adding any energy-dense fat is going to be beneficial. But in populations consuming a typical Western diet, the specific type of saturated fat matters immensely. We need to walk down the supermarket aisle and look at where this fat is actually coming from.
I agree. The source matters.
Not all saturated fats have neutral effects. Let's look at the food matrix, specifically comparing dairy to meat. Evidence points heavily to palmitic acid, which is highly concentrated in processed meats, as having a strong association with cardiovascular risk. The guidelines cap saturated fat because the primary vehicles for it in the standard American diet are often highly processed foods like sausages, bacon, and grain-based desserts. If we drop the broad cap on saturated fat, we are implicitly giving the public a green light to consume these highly atherogenic foods.
Actually, your point about the supermarket aisle proves exactly why a broad, sweeping cap on saturated fat is scientifically unjustified. We should be focusing on the foods themselves, not isolated molecules. You brought up dairy, which is the perfect example. The 2025 Dietary Guidelines Systematic Review itself showed that substituting higher-fat dairy for lower-fat dairy does not change cardiovascular morbidity risk.
But it doesn't improve it either?
Furthermore, meta-analyses have shown that whole-fat dairy, cheese, and even butter have negligible links to all-cause mortality or cardiovascular disease. In some cases, there is an inverse association with diabetes. This is because of the food matrix. Milk fat contains short and medium-chain fatty acids, and it's encased in something called the milk fat globule membrane.
The MFGM, yes.
Right. This membrane is a structural casing around the fat in whole dairy that completely changes how our body digests and processes it, actually offering cardiometabolic benefits. By telling the public to keep all saturated fat below 10%, we are effectively telling them to avoid nutrient-dense whole foods like full-fat yogurt and cheese. The true risk you were talking about with processed meats is heavily conflated with the extreme sodium levels, the chemical preservatives, and the lack of fiber in the diets of people who eat a lot of hot dogs and bacon. It is not the saturated fat molecule itself causing the damage.
Look, while I agree that the milk-fat globule membrane and fermented dairy products like yogurt have unique metabolic benefits, we cannot extrapolate that to mean saturated fat as a macronutrient, one of the major building blocks of our diet, is harmless. Palmitic acid is palmitic acid, whether it comes from butter or processed sausage. The matrix absolutely modulates the absorption and the body's response, but high intakes of saturated fat will still downregulate LDL receptors in the liver.
In some people, yes.
That means your liver clears less cholesterol from the blood, leading to higher circulating apolipoprotein B. The rigorous substitution models in the 30-year follow-up of the Harvard cohorts demonstrated that replacing dairy fat with vegetable sources of fat significantly reduces cardiovascular risk. So even if we concede that whole-fat dairy is neutral compared to refined carbohydrates, it is still physiologically inferior to unsaturated plant fats. If our goal is optimal prevention of heart disease, the hierarchy of fats remains crystal clear. Polyunsaturated and monounsaturated fats at the top, saturated fats lower down, and trans fats at the very bottom.
The concept of optimal prevention cannot be separated from an individual's metabolic context. We are treating the public like a monolith. Let's look at the precision nutrition aspect. such as the APOE4 genotype. We know that genetics heavily influence how different bodies handle lipid metabolism. But even more broadly, look at populations with atherogenic dyslipidemia.
You're referring to the high triglycerides, low HDL phenotype.
Yes, it is a very specific and dangerous lipid profile. High triglycerides, low good HDL cholesterol, and a ton of those dangerous, small, dense LDL particles we talked about earlier.
Restricting saturated fat does not fix this problem. Carbohydrate restriction fixes it. When you put patients with metabolic syndrome on a diet that is higher in saturated fat but very low in refined carbohydrates, their triglycerides plummet, their HDL rises, and their small, dense LDL particles transform into the benign, large, buoyant particles.
Because they are losing weight and lowering insulin.
Exactly. If saturated fat were inherently toxic to the cardiovascular system, putting an insulin-resistant patient on a high-fat, low-carbohydrate diet would rapidly accelerate their heart disease risk markers. Instead, we see the exact opposite: profound, rapid improvements in systemic metabolic health. The diet heart hypothesis operates in a vacuum, assuming a perfectly healthy, lean individual. But in our modern environment, where the vast majority of adults have some degree of insulin resistance, strictly limiting saturated fat while allowing high carbohydrate intakes is actively counterproductive to public health.
And that creates a bit of a false dichotomy, though. We do not have to choose between a high saturated fat, low carbohydrate diet and a low fat, high sugar diet. Look at the Mediterranean dietary pattern. It restricts saturated fat to very low levels, emphasizes polyunsaturated and monounsaturated fats from olive oil, nuts, and fish, and includes high-quality, low-glycemic carbohydrates from beans, legumes, and whole grains.
Which is a fantastic diet, I agree.
It is. And this pattern has undeniably robust clinical trial data, such as the PREDIMED study, showing massive reductions in cardiovascular events. It achieves the exact metabolic improvements you were talking about, lowering triglycerides and raising HDL, without needing to load the system with saturated animal fats. The consensus remains that replacing saturated fats with unsaturated fats improves lipid profiles safely.
Safely, sure, but is it optimal?
Furthermore, we have to look at Mendelian randomization studies. These are basically nature's own clinical trials, where people inherit a genetic lottery ticket that keeps their LDL naturally low for their entire lives. These studies show that lifelong exposure to lower LDL cholesterol drastically reduces heart disease risk. If saturated fat reliably raises LDL, and lifelong low LDL is causally linked to preventing heart disease, the public health mandate to limit saturated fat is entirely justified. To walk back these recommendations now would confuse the public and potentially reverse decades of progress in lowering population-wide cholesterol levels.
But is it the low saturated fat that makes the Mediterranean diet so successful? That pattern is rich in polyphenols, fiber, omega-3 fatty acids, and anti-inflammatory compounds. It completely eliminates ultra-processed foods and refined sugars. To attribute its success primarily to the restriction of saturated fat is a classic case of confounding variables.
It's a synergy of all those factors, including low saturated fat.
Furthermore, when we look closely at the European Perspective Investigation into Cancer and Nutrition, the EPIC cohort, which is massive, we see that the association between dietary saturated fatty acids and ischemic heart disease depends entirely on the source. In that cohort, saturated fat from fermented dairy was actually inversely associated with heart disease, meaning it was protective. We are stuck in a 1970s paradigm where we treat human nutrition like a simple math equation. Fat equals cholesterol equals plaque. But the human body is a highly complex, dynamic system.
It is complex, but the ApoB mechanism is still central.
The inflammation that drives the oxidation of LDL is far more strongly linked to hyperinsulinemia and excess omega-6 linoleic acid than it is to dietary stearic or palmitic acid from whole foods. When top-tier journals like the Journal of the American College of Cardiology publish state-of-the-art reviews explicitly stating that the current level of evidence does not clearly support guidelines restricting saturated fatty acid consumption, we have a duty to listen.
The insistence on maintaining the 10% cap feels like an institutional reluctance to admit that the singular focus on saturated fat was a misstep. The history of nutritional epidemiology is fraught with unintended consequences. It is time we stop hyper-focusing on isolated saturated fat molecules and start looking at overall dietary quality.
As we synthesize these perspectives, I think it's important to recognize how the science of nutrition has undoubtedly added vital layers of nuance over the decades. We now deeply understand the importance of carbohydrate quality, and we absolutely recognize that the food matrix plays a significant role in how our bodies process different fats. However, that nuance does not negate foundational physiology.
Right. Physiology still applies.
Exactly. The preponderance of clinical, genetic, and epidemiological evidence still dictates that saturated fat raises atherogenic LDL cholesterol. Replacing saturated animal fats with polyunsaturated and monounsaturated plant fats remains a proven, highly effective strategy to optimize lipid profiles and protect against cardiovascular events. The public health guidelines are not outdated. They are a distilled, practical application of the strongest available evidence to protect the broader population from the leading cause of death globally.
And from my perspective, I must conclude that strict, universal limits on saturated fat are indeed an outdated paradigm. The totality of the evidence, particularly from massive modern global cohorts and updated systematic reviews, shows us that natural saturated fats, especially those from whole-fat dairy, are not the dietary villains they were made out to be. We need to urge a shift in focus away from myopic nutrient caps that treat all saturated fats as equal. Instead, we must address the real drivers of modern cardiovascular disease: systemic inflammation, insulin resistance, and the massive overconsumption of ultra-processed foods and refined carbohydrates. Reintroducing nutrient-dense, whole food sources of saturated fat into a low-sugar, high-quality diet is a perfectly healthy, evidence-based approach to cardiovascular wellness.
I think where we fundamentally converge today is on the vital importance of the replacement nutrient. What replaces a nutrient is just as important as the nutrient itself. We are in absolute agreement that replacing any dietary fat with refined starches or added sugars is universally detrimental to metabolic and cardiovascular health.
Absolutely. The evolution of nutritional science clearly points us away from simplistic good versus bad labels. Listeners should look beyond single isolated nutrients to understand their food choices within the much broader context of their overall dietary pattern, their physical activity, and their individual metabolic health. There is much more to explore in this material.
Thank you for joining us on The Debate. We leave it to you, the listener, to draw your own conclusions.